There isn't an IC patient out there who cannot relate to this meme. You know, when that next stop is 20 minutes away, God forbid there be a traffic jam, but you have IC and you've got to go. Why? Because it hurts. Restroom access is really important for IC patients. So I wanted to share a professional presentation I did for an international group of doctors who are studying chronic pelvic pain. And it's about how do we want doctors to work with us? Because my job is to represent the IC patient community, and I really want to know if I got it right. What did I miss? So at the end of this video, would you share some comments? Because I'd love to hear what you think. But let's go through this presentation now. It's not that long. So our title, The Right Attitude for the Assessment of Pelvic Pain from the Perspective of Your Patients. My name is Jill Osborne. I'm the founder of the IC Network. I'm the U.S. National IC Support Group Leader, and I do live support group meetings weekly via YouTube and Facebook. I'm the longest serving support group leader in the world at 30 years. Yes, I am that old. But the ICN has also been rated the best on the web in 2 peer-reviewed medical studies. But I'm also a pelvic pain patient and have been since the age of 14 after breaking my tailbone. Of course, we didn't realize that's what triggered it. Now in hindsight, we know. I have the typical progression of symptoms. I had frequency urgency first. I couldn't sit through class. I drove my teachers crazy asking to use the restroom. I developed a urethral stricture where my urethra became very, very tight and it felt like I was trying to pee through a needle. I developed severe vulvodynia in high school. I felt like I had a yeast infection all the time. I developed severe IBS in my early 20s. I had what I called bend over and screamer cramping almost every morning for years. I developed some migraines, and then in my early 30s, I developed severe bladder pain. My phenotypes are myofascial pelvic pain, aka muscles, and central sensitization, aka nerves. My treatment is physical therapy and mind-body medicine to calm my nerves down. And I am currently pain-free with the exception of a wonky TMJ. This is the single most important phone call I've received since starting the IC Network. It was many years ago, and it was from a man who was sobbing. He couldn't speak. So I whispered to him, we did some deep breathing together, and what he eventually said absolutely stunned me. He said, I'm the chief of one of the biggest trauma units on the East Coast. I have IC and pelvic pain. I live with pain every day, and I've told no one at work. And I said, why? Because, of course, we all need support. And he said, because they laugh at patients and believe it's a mental illness. And the minute I tell them, I will lose all of my professional credibility. I can't do this anymore. I need help. Imagine that's how a doctor felt. So what do we patients want from you, our medical care providers? Number one, we want a kind detective who will help us figure out why we are in pain and what we can do about it. We want someone who listens. We want someone who believes we are struggling. We want someone who will help us when we are scared and in pain. And we want someone who will teach us how to get better. But just as we see in IC support groups, we also see 2 distinct and very different patients in clinic. Our first-timers versus our grizzled veterans. And they have very distinct needs. So for that first timer, this is their first appointment to discuss pelvic pain. They have a recent onset of symptoms. They have little education other than the internet and social networking. They are embarrassed to talk about intimate problems. They may be worried about cancer and other life-threatening conditions. I certainly was. I was completely convinced that I was dying of cancer my first year with IC. They are desperate for a diagnosis, but they are usually hopeful and open to your suggestions. In contrast, we now have the grizzled veteran, where you are their second, third, fourth, fifth, or sixth consultation. They have failed multiple therapies. They have intense pain and insomnia. They may be unable to work and are in financial or housing distress. I can promise you that at least one person has told them that it's all in their heads. They now have very little trust in medicine, and they feel hopeless and depressed and may be struggling with some suicidal ideation? I certainly did. So how do we want you to approach the newbie? Well, the newbie needs an upbeat, encouraging, and informative appointment. And while we may lack knowledge, we often have an intuitive sense of what triggered our symptoms. So please ask, is there any event that you associate with the onset of your symptoms? What do you think caused it? Now, the newbies may not know how to describe their pain or where it is. It just hurts down there. You know, it's down there. So simple questions really help. Like, where do you think the pain is coming from? Is it on the inside of your body, or is it on the outside on your skin? Does the pain occur before you urinate, while you're urinating, or after you're done urinating? Or does the pain change based upon body position? Does it get worse when you sit down, and does it get better when you stand up? Now, our newly diagnosed patients are desperate for educational information and self-help tips. And you can find excellent materials to hand out on the IC Network website in our free download area. But you can also find some good materials at facingpelvicpain.com. And for those clinicians, please consider using symptom checklists, assessment forms, and videos, which you can find at facingpelvicpain.com or pelvicpaineducation.com. Why? Because it will save you time so that you can do a more comprehensive diagnostic interview and assessment with your patients. So now what are we going to do with these newly diagnosed patients? Well, we're going to do phenotyping. Why? Because pelvic and bladder pain is remarkably heterogeneous. For some people, this begins in childhood. For others, after menopause. For some, it begins after having a baby or another pelvic surgery. While for others, it begins while going through chemotherapy. And please do not assume that a disease is triggering pain. For most IC patients, it's neuromuscular in origin. Now, phenotyping will help you identify the most effective treatment modalities for these patients, and phenotyping will also save you time and that patient money as they begin to explore treatments. So what are our IC phenotypes? Well, Dr. Chris Paynes, formerly of Stanford University, was the first to propose that there were at least 5 distinct patient groups: Hunner's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, and central sensitization. And this is the system I have used for over 5 years, very, very effectively here in the IC Network office, because it helps patients understand context. It helps them understand their potential causes, but also where treatments fit in, the most effective treatment for their unique case. Now, the American Urology Association, the U.S. National Institutes of Health, well, they don't change easily. They want a lot of data and research supporting these new theories. And thankfully, we have that now. And so last year, in our updated IC guidelines produced by the AUA, they supported 3. They basically combined some of Dr. Paynes into 3 basic groups: bladder wall driven, which is Hunner's lesions and estrogen atrophy and like that; pelvic floor driven, which is pelvic floor injury and pudendal neuralgia; and of course, that widespread pain patient. Now, interestingly, in late 2022, early 23, Dr. Curtis Nickel, our top IC researcher in Canada, proposed 9 distinct patient groups. He basically added to the Chris Paynes system by including urethral pain, UTI-mediated pain, allergenic pain, primary storage symptoms, flares, etc. But what makes his proposal all the more compelling is he also published his recipes for treatment. Now comes the challenge. How are we going to approach these grizzled veterans, these patients who are really struggling and suffering? Well, number one, they need a master detective and expert in pelvic anatomy. And please assume that they have some knowledge, but it's often outdated. Why? Because they kind of gave up years ago and stopped reading. So they may not know about the new breakthroughs and new phenotyping, etc. And please understand, too, that they believe that they will be in pain for the rest of their lives. But here's a question you need to ponder with these patients, and that is, if our bladder therapies failed, then is it really the bladder? Because some of these patients have been doing bladder therapies for 5, 10, 15, 20 years, and they still flare and they're still having problems. Why? Well, maybe it's not their bladder. Maybe it's something beyond their bladder that is triggering these symptoms. So central sensitization patients need nerve calming techniques. So please reinforce the concept of injured nerves or muscles causing neurosensitization, aka a central nervous system maladaptation. And the International Pelvic Pain Society has excellent resources on this. I recommend their annual meetings and courses to any medical care providers working with IC and chronic pelvic pain. And of course, at this appointment, you must probe gently about past trauma, whether it be physical injury or emotional abuse, with, of course, very gentle trauma-informed care principles. You will be very surprised by the number of patients who have coccyx injuries, who have fallen downstairs, or who sadly were victims of childhood abuse. One of the trends I see in my office are children who were raised in the home of a violent alcoholic, where literally for their entire childhood they were afraid. And once that parent came home and started drinking, they got more and more scared. They got more and more fight or flight. And essentially, their brain became adapted to fight or flight. So for these patients, we have to explain that we must calm the central nervous system and train that brain away from fight or flight to reduce pain throughout the entire body. How do we get the brain out of fight or flight? With mind-body medicine. It's worth trying. It changed my life. Now, another thing we've got to consider is that these patients will be struggling with anxiety. They will be the no people. Hey, you want to go out to dinner? No, it'll flare me. You want to go to a movie? No, I won't be able to find a bathroom. You want to go take a drive? No, I'll probably have to use the restroom. Why is that patient the no person? Well, that's a sign that their brain is guarding. It's guarding. It's trying to protect them. The problem is that the anxiety is so intense, it's like every other thought is a scary thought. And whenever they have that scary thought, they go right back into fight or flight. So probably the single most important thing I did is when I was 35, I got sick of having the panic attacks, is I found a class in anxiety management, and it completely changed my life. Because I understood, number one, the long-term toll of anxiety, that you're basically swimming in adrenaline, you're swimming in fight or flight, and that's raising your blood pressure, and that's raising your heart rate, and it's tightening your muscles. There's a long-term toll to be had for being in chronic fight or flight. So what we've got to do is get some new, better anxiety management tips and techniques. The IC Network has some excellent resources, and I also have a video where I talk about the class that I took that has just made a tremendous difference in my life. So here's a quote that's very important. If the usual IC therapies provide no improvement in symptoms, then the clinician should revisit the diagnosis of IC and consider whether an unidentified disorder may be present that is producing symptoms. This consideration may require additional diagnostic workup and/or a referral to appropriate specialists. Why? Because we now know why bladder therapies often don't work because of the neuromuscular origins for so many of us. Bladder therapies never worked for me. Physical therapy did work for me. So if that patient is not responding to therapy, if they're getting worse rather than better, we've got to take a step back, revisit the diagnosis, and ask, gee, could we have missed something? Could we have missed a pelvic floor injury? Could we have missed a broken tailbone or a problem with a hip or an SI joint or a foot? Could we have missed pelvic congestion syndrome or endometriosis? We want to do a much more aggressive diagnostic workup for these patients who are non-responders. And here's a quote from my favorite author, Dr. Jerome Weiss. He says, "One size does not fit all when treating chronic pelvic pain. The therapeutic approach must be tailored to the patient's unique needs. Therefore, I regard every case as a mystery to be solved and have made it my mission to help patients that others have labeled as difficult and untreatable." Now, here are my go-tos. For the veteran patient for which the mystery of their pain has not yet been solved, I recommend Facing Pelvic Pain. It is a fabulous resource that will go through the many, many potential causes for their bladder and pelvic pain, from orthopedic issues, muscle issues, reproductive tract issues, bowel issues, neurology, rheumatology, etc. Super easy to read, short chapters, an excellent resource to give to patients to engage them also in trying to solve the mystery of their pelvic pain. For our patients where we have a very clear muscular origin, there's nothing better than Breaking Through Chronic Pelvic Pain, a holistic approach to relief by Dr. Jerome Weiss. It is a master class in pelvic anatomy, and it is filled with fabulous, encouraging case studies. I want patients, as they're working with physical therapists, to be able to visualize exactly what they're touching and where it is. So the more knowledgeable that patient is, the better they're going to be able to work with physical therapy and proceed through trying to heal those muscles. And of course, for the newly diagnosed bladder and pelvic pain patient, IC 101 is not just a bladder disease. This is our first book that introduces the concept of phenotyping. It's also filled with all the information on the potential treatments, excellent self-help tips, and more. So I want to thank you for helping us to be whole again, because we want to be able to work and travel and go on vacations and have sex and go to football games and baseball games and movies. We want to enjoy life with our families and friends. And so thank you so much for helping us on this journey. All right, that's the end of the presentation. Now you patients, you tell me, did I get it right? Did I miss something? I would really love to hear your feedback. So again, down in the comments, tell me what you think. Love to hear your thoughts. And don't forget, if you like our videos, make sure you subscribe and click the bell so you get notified when I go live with breaking news stories, with our support group meeting, or when I put up a new video. Thank you so much for watching. I'm really curious to hear what you're going to say about this video.